Our speakers for today's presentation are Dr. David Wall. Dr. Wall is a professor of medicine in the Division of Infectious Diseases at the University of North Carolina. He is co-principal investigator of the Global UNC Infectious Diseases Clinical Trials Unit and site leader of the Chapel Hill Research Site. He is a clinical scientist with a focus on emergent infectious diseases and has spent over 20 years leading research into the prevention and treatment of HIV and served 2 terms as a member of the Department of Health and Human Services Antiretroviral Guidelines Panel. In 2020, he helped lead the UNC clinical and research response to COVID-19. He is medical director of a large drive-through testing site, as well as 2 COVID-19 vaccination clinics. He serves as vice chair of Active 2 at an international AIDS clinical trials group, Operation Warp Speed trial of SARS-CoV-2 therapeutics. He also has an active clinical practice at UNC. Our second speaker today is Dr. Sam Weir. Dr. Weir is an active practicing family physician at UNC Family Medicine. He serves as the medical director for the Care Access and Service Integration Department that has worked with UNC Health, ISD, and operational units to develop the workflow for ordering COVID therapeutics such as monoclonal antibody treatments for appropriate patients. I will now turn it over to Dr. Wall. Dr. Wall, if you would like to share your screen.
I will. Thank you.
Thank you.
Well, thanks everyone for being here and taking time out. Try to make this bigger. There we go. Okay. Well, thanks again, and thanks for this opportunity. It's great that Dr. Weir is able to co-pilot this with me. I think what we're trying to do is maybe not go over too much didactic content, but give you sort of an overview, really big overview, because any one particular topic that we could talk about with COVID-19, whether it be epidemiology, vaccinations, other preventive measures, mitigation strategies, therapeutics, really are just for a full day symposium, let alone a half an hour to 45-minute overview and discussion. I do think we want to highlight monoclonal antibody therapy and prevention just because it's such a big deal. It's newer for a lot of us. It's not something that many of us were dealing with just a few months ago. So we'll try to spend a little bit more time on that, and also how to operationalize that if there's any questions. So I'm going to kind of go quickly, and then if we have questions, which I hope we do, I'll stop sharing my screen and we can just take some of those. Yeah, so this is a really big challenge for me to try to think about like what to cover, and I'm just going to go over some maybe top line things that could be a tickler for additional conversation. So I've broken it down into the epidemiological, the virological, prevention, and treatment, and we'll move through these, as I said. So a lot of these slides I borrowed, quote unquote, from David Weber, and they really are pretty striking. And if you've heard David talk, it really is chilling to hear him talk about some of the epidemiological features or characteristics of COVID-19 that maybe many people don't understand or disregard at their peril. So here's really just an incredible graphic showing deaths from COVID-19, other pandemics, and armed conflict from the United States. And you can see that it's estimated that we'll hit about 750,000 deaths by the end of this year. And I've been working, as Gina said, on a different pandemic, HIV, and this number of deaths that we're talking about here will surpass what we've seen from HIV/AIDS, surpasses Spanish flu, of course, per capita, that was much more devastating. And then, all the way, down through, wars and some of the things that we talk a lot about, 9/11 attack, you can see really just a much smaller number compared to what we're dealing with here. In fact, it's not a surprise, and this is twice in my lifetime that something has come on the scene and then been responsible for a large proportion of people dying. HIV was the first. And here we could see COVID-19 already taking its place as the third or fourth leading cause of death in the United States, and around the world. Even more people are dying, of course. So we can see that this is a huge cause of morbidity and mortality. Again, just to, why the big deal? Why the lockdowns? Why the mandates? These two slides, I think, help explain the why. This one as well. And this is really, it could choke you up. I mean, when you look at this, the impact of COVID-19 on life expectancy in our country is fairly profound. And you can see here on the left, life expectancy, what we would have without COVID-19 is in orange, and with COVID-19, it's shifted over to the left in blue. So this is really curtailing benefits of advanced civilization, of modern medicine, of technological innovations, of hygiene. When you look on the right, you can see for different populations just the dramatic effects this has had on, especially on people of color, especially on Latinx population, that's had much greater dips in life expectancy than the overall population or the white population. And we know that we're in the midst of yet another surge. And these are older data, so we know that this has peaked even higher. And we also know that the vaccination rate hasn't really changed from a month ago, and that we still have a large proportion of the population that's unvaccinated and that will be unvaccinated, and that's just a given. But we do have a lot of folks who are vaccinated, and we'll talk about what that means and maybe what that portends for the trends moving forward epidemiologically. We talked before, and my colleagues often ask us not to use the term herd immunity because we are not cows, and also because there really isn't full immunity. So population immunity might be better, or population protection. And I think that makes much more sense. But people understand it as herd immunity. And one thing that I think is becoming clearer with the Delta variant, as we'll talk about in a second, is that that concept may no longer apply. As long as we have a sizable number of people, especially clustered in certain places, whether it be a town or county or region, we're going to have people getting really sick if they're unvaccinated. So we're going to have people who are not immune from one reason or another, who are going to be susceptible to COVID-19 for a while, for a long time, while others of us will be more protected. Interesting, looking at blood bank data, it could be we've already achieved over 80–85% of the population having some protection or immunity against COVID-19, either because of infection, which is the minority of those, which is great, but or vaccination, but combined maybe about 80–85%. So that was a number we talked about earlier. If this is representative, which it may not be for the general population, of course, because blood donors are different. But if it is, it shows that we have achieved some of the thresholds, but we haven't achieved the end of the pandemic. So Delta is different, and we're going to have these pockets, whether they be on the borders of North Carolina or elsewhere in the Midwest, central US, where there's unvaccinated people in large gatherings and large groups. We're going to have burdens on our healthcare system. This is hard to read, but it's a projection that's been pretty accurate from the University of Washington. And the bad news is the lines aren't really going down dramatically as you move to the right, which is the end of the year. So this says today, and that was a couple of weeks ago. But if you move over, we're probably, again, this is already accurate, and it's about a month old. It shows us that we're starting to see a leveling off of new cases, of deaths, of the need for hospital beds, which is purple on the bottom, and ICU beds, which is green on the bottom. We are starting to see this happen right now, and the projection is that this would continue. I'm a little worried that the cold weather and the bump that we usually see in coronaviruses during the cold weather is not factored in here, and hopefully this will continue to go down, and we won't see sort of a camel hump of an increase again, a late surge due to the cold weather and the gatherings of people, and maybe some of the strategies that are in place now, including third shots, may help mitigate that, is at least the hope. As I think all of us who work at the UNC healthcare system know, those data really translate as well to our hospital burden, whether it be on the COVID wards or in the ICU. We've seen a leveling off right after this. These data, we saw really a nice plateau, not a dramatic decrease, but a plateau. We still are very stretched, but we didn't continue to see this increase in hospitalizations, in ventilator use, in ECMO. And that's a good sign. And as we'll talk about in the outpatient setting, even monoclonal antibody therapy, we're seeing double-digit decrease, low double-digit decrease in demand for monoclonal antibodies. Again, very reassuring. When we look at trends overall, one of the things we're seeing, we'll get into this a little bit more in a second when we talk about virology, is we're seeing that the infections are skewing younger. And all of us appreciate that and know that. And that's a confluence of a few things, right? One is older people are heavily vaccinated. So that's great. And they've been vaccinated for a while, which we'll talk more about when we talk about possibly waning immunity. But we've seen a good uptake, and also good uptake of mitigation strategies by older people. I don't think it's only vaccines alone. There's other behavioral factors that I think are playing into it, where older people are wise and being cautious. Younger people, not the same sort of situation. And we have seen, for different reasons, including virologic reasons, but also sociological, increases in people coming into the hospital, including those who are sick, who are younger. And that's been something different with this variant that we've seen with other variants, and it is really concerning. And anyone who's working in the hospital now will tell you that the peak age is in their late 40s, early 50s. It's not the 70s like we used to see this time last year. These are data again from UNC Medical Center, and you can see hospitalizations and deaths by age group. And hospitalizations are again mostly in older people, but 25 to 49 is not that old, and that's the number one. And we are seeing people who are even younger than 25. On the right, you can see the bands. If you're talking about orange, that's a significant band with this big surge that we're having now. So that's just tragic. As we've heard and read, there are parts of the country where they've run out of pediatric ICU beds, including due to RSV, which is also surging at the same time. And even just positivity, not just getting sick, but this reflects, it's the tip of the iceberg, of course, because if you have a lot of folks younger who are getting sick, that means there's a lot more people younger who are getting infected. And the blue line shows the percentage of positives that are under 18 years of age. And we've seen some peaks and valleys in the past, but nothing like what we're seeing now. So why is this happening? Well, this is it. This is Delta. And we can see very, very dramatically how in a very short period of time from about the beginning of June or late May up to now, the dominance of this variant, and I've looked at other data that really nicely describe how quick this has happened compared to other variants, and there's nothing like it. Every other variant really had to claw its way to the top. This just had a complete ascension over a very, very short period of time, which shows that this is a virus that is fitter in many ways than previous variants and able to spread and crowd out other variants from coming in. And that may be a silver lining. But we do see that this variant has taken over. And this has occurred at the same time that other things have happened. This is why there's confusion and I think some whiplash from CDC recommendations and some state guidance, because I don't think anyone anticipated that something like this would happen, of course. And so at the same time that you see Delta coming onto the scene, and this will have an impact on our discussion about vaccines and their continued protection, we saw, removal of mask mandates and mitigation strategies. We started to see the holidays and people open up more. And we started to see guidance that told us it was okay to be around other vaccinated people without masks on, which with Delta probably is not a good idea. And so we also started to see breakthroughs. And when I talk about breakthroughs, I'm talking about infections, not as much hospitalizations, and we'll differentiate that in a second. But we started to see people who are fully vaccinated actually getting infected, at least transiently, and being able to spread the virus to others. So there's a confluence of events here. There's also a concern that people who have Delta, not only is it hyperinfectious, not only do you see more virus in the nose and throat in people who get Delta, and maybe for a longer period of time if you're unvaccinated compared to other variants, it also can make people sicker. And I think there's enough data now to suggest that Delta is worse, and that may explain why we're seeing younger people succumb to Delta the way that we have. This is an amazing, amazing graphic, and this is generated by the McClendon Clinical Laboratory by Melissa Milla and Herb Winna and their colleagues at the clinical lab. And what they've done is really taken a very, very proactive approach to surveillance when no one else was doing this in a big way, and certainly not the CDC. They've been sequencing most every virus they get, some sent from you all, most that come from our drive-through and other RDCs when they were open, but almost every virus that they get in that lab, they try to sequence. And what this shows you is Delta in the hot pink. And it didn't take gradual, like Alpha. Look at all the months it took before Alpha was able to climb to the top. Green just represents any variant of interest or concern. So that's cumulative. And then Delta just came along. This tells you a tremendous amount. It tells you how quick this was and how hyperfit this is and how hyper-infectious. It also tells you that 100% practically of the virus that's circulating now is Delta variant, and that has not changed. This is also a very fascinating graphic. This is from Singapore, and this is people who get hospitalized. Now in Singapore, they have a lower threshold to hospitalize people than we do. So this is not just really, really sick people. But what you're seeing is the viral level. And on this graph, higher up means more virus because you're getting to a lower CT value. CT value is inverse. We won't get into it, but a low CT value means more virus. And so you're looking at pink unvaccinated and then green vaccinated. These are people who are completely vaccinated. So if you look at the far left, you can see the green and the pink dots are pretty indistinguishable as far as any pattern. They're both high level. That's a pretty high amount of virus when you're talking about a CT value of 20 or 10. But what you see over time is the people who are unvaccinated, that red just keeps staying there at the high levels for a longer period of time. And whereas the green drops down, and my son astutely pointed out when he saw this, he's 17, he's like, you don't see at the very bottom, when people get to basically undetectable, you don't see any red for a really long time. It takes 2 weeks before some red people start to get to that low level. And then it's not really until maybe 3 weeks that red really starts to get to undetectable. So not only is it longer, it's higher level and fewer people who are unvaccinated. So when people say, well, why should I get vaccinated? If they could only understand and see this, they would understand that vaccine not only does it protect you from getting infected, which it does, which this data doesn't show you, but we have other data that do show vaccination protects you from getting infected. If you do get infected, you're going to start out with a pretty high viral load, but very quickly it's going to go down relative to people who are unvaccinated. And not shown here, but in other data that we'll talk about, the chance of it going down into your lungs and getting you in the ICU or getting you even on a COVID ward is much, much lower. And we see the hyperinfectious nature of this in a celebrated case in an elementary school where there was a teacher who did not have a mask on, and just the distribution within the classroom where those who are in the first row, the children in the first row, were largely infected, but even some kids in the back were not spared. So this traveled across the room. This gets into a whole nother discussion around ventilation that I am not able to talk about, but not every room is created equal. Sitting 6 or 10 feet from someone indoors without a mask in some rooms is safer than in other rooms, and that's a very complicated situation. And I feel very uncomfortable indoors without a mask on because I don't understand fully what's going on with the ventilation. And so that's a really, really important thing for an aerosol like this that traveled down, across this classroom and did infect some of the kids, outside of the immediate cloud or spray area of this teacher who was infected, symptomatic, and didn't wear a mask. Let's talk a little bit more about protection. This is a hot topic, and I'm not doing it any justice. I'm sorry. It's complicated. There's a lot going on, and it's changing all the time, but we can talk about it further. But is vaccine immunity waning? Vaccine immunity has to wane eventually. It's just a matter of the timing and what's the right moment to act proactively rather than reactively. So when we talk about vaccine efficacy, VE, against infection, that's one thing. When we talk about vaccine efficacy against hospitalization, it's really another. And so these data from New York State have been my go-to for a while, just to keep optimistic. So this is May through July. So we're starting to get Delta, because as I showed you before, Delta was taking over kind of in the middle of that range. And this is New York State data, a lot of good data, good epidemiological data, thousands and thousands of people, good distribution of vaccine uptake, whether it be Pfizer or Moderna and some J&J. And you'll see, again, by August of this time period, as we'll see some of the data, all of it's Delta. So what do you see? Well, first, the bad news. The bad news is that over time, the viral efficacy, the vaccine efficacy, and this is broken down by age groups, and you can see the different colors in the legend, but overall, the vaccine's efficacy against infection, against testing positive, started to go down from that fabled 90-95% to about 70%. And so that's concerning. And that's the breakthrough that a lot of people are talking about. That's the breakthrough that concerns us, whether you're an Olympian or you're a baseball player or you're a neighbor. I was fully vaccinated and I got infected. But these are not sick people. This is hospitalization. And you can see over the same time period for all these different age groups, including the 65 plus, there really wasn't a dramatic change as far as the vaccine's efficacy against hospitalization. And so that's really, really reassuring that at least over this time period, at least over these many months from when these people were vaccinated, in New York with Delta, prevailing, we didn't see massive, hospitalizations with people who were fully vaccinated. And that's the same here in North Carolina. We do not see our ICUs or our COVID units overwhelmed or even any parity. Again, 90% or so of people in the ICU with COVID-19 are people who are not vaccinated, and certainly not fully vaccinated. And some of the people who are fully vaccinated are older, they're on drugs like rituximab, not all, but many. And so they have comorbidities that may have been associated with them not responding to the initial vaccine or having an accelerated waning of the vaccine's protection. There are other studies. I don't have enough time to go into it. The New York study is in the blue here. That's looking at infection and then hospitalization here in this red. But there are other studies that kind of show some of the same thing or maybe more dramatic decreases. So some of the data on hospitalization are mixed, where some are seeing some increases. We do also see that probably the protection, you're not going to like this, but the protection for Pfizer versus Moderna doesn't look as good. So surprisingly, Johnson & Johnson is looking very robust, even though it's one dose, and maybe just due to numbers, but we're not seeing the same waning in the data sets that have looked at it. So that's interesting. And so the J&J people who feel left out should maybe not feel so bad after all, but it does look like Moderna has an advantage in most of the studies over Pfizer. And that helps us when we talk a little bit about Israel, because Israel is almost 100% Pfizer. They're not using Moderna. And Israeli data are interesting. And they have a much more unified healthcare system. Basically, everyone in the country is mandated to belong to one of 4 HMOs. And those HMOs, by law, have to share data. And so they have a lot of data, and they're able to mine those data. And what you can see here is stratification by different age groups and the timing of when people got their vaccines. So for the age 60 plus, people who got it about 6 months ago, and the confirmed infection rate per 1,000. And what they're showing is that people who got vaccinated more recently have less cases of COVID-19 compared to people who were vaccinated further back in time. And this is true for most every age group they're looking at, suggesting maybe this waning. And this motivated them, along with other trends, to start their 3rd dose of Pfizer, first for older people and then for others. And they really were one of the leaders in thinking about, quote unquote, boosting of people who had already gotten their initial series. And they have some data showing that there's maybe some protection from that, but it's very, very early, not a long-term follow-up. So we have to see more from this. What about treatment? This is really, in some ways, disappointing, and it's a shame. We've really come so far with vaccines. Those vaccines are really good, and they're doing amazing work, and we just have to get more of them into people's arms here and across the world, and there's a lot of discussion, as you know, about that. But they're great, and they really are, and they're only going to get better. But what about therapeutics? Not so much. So outpatient, all we can talk about right this moment are monoclonal antibodies, and we will. And these are directed against the virus. They have prevented, of course, from entering into the cell, and they help with cell-mediated killing and optimization. Inpatient, it's only slightly better, maybe. If you talk to anybody, and maybe some of you work inpatient, taking care of COVID-19 patients, very few people are enthused about any of these except maybe corticosteroids. I think corticosteroids have saved many people's lives, but it's hard to say that remdesivir, tocilizumab, baricitinib, and some of the other things that we're using, but most of these are what's in the quiver, are really making a dramatic difference. And there's some mixed data for all these things, although maybe together, and there's less data on the combination, but maybe together they are moving the needle in a way that has helped decrease mortality, along with all the other things that we're doing, like having nurses who are very experienced respiratory therapists work with people, and proning and using oxygen early, and those types of things. So what about outpatient monoclonal antibodies? This is really what I think we want to launch into for the rest of the time, but I will touch upon inpatient just for about 30 seconds. But these are all under EUA, just like the vaccines, emergency use authorization. There are 3 products out there right now: BAM, EDI, CASI-MD, and Sotro. BAM, EDI, and CASI-MD are a combination of 2 different monoclonal antibodies in a cocktail. We used to have BAM alone, but BAM alone doesn't work against Delta or against really any of the newer variants of concern. And BAM, EDI, and CASI-MD are purchased by the federal government and made available to hospitals and clinics, where Sotro is not. So Sotro has to be purchased just like any other pharmaceutical product. It has a longer half-life, so it actually may have some value that's different than the other 2, but much less experience clinically with this. This is why they're available, because of studies like this. This is a pretty large study of about 750 people per arm who had COVID-19, who are outpatients with some risk factors for hospitalization, and were randomized to placebo versus Regeneron-COV, which is CASI-MD. And you can see the Kaplan-Meier for yourself. The events here are hospitalization or death. This is not a lot of death. This is much more hospitalization, including ED visits. There are a few deaths. Good thing about all these studies is across all of them that I'm going to show you for these monoclonals, nobody who got a monoclonal died. So there were very few deaths, but all the deaths were in the placebo arms. So this is a dramatic decrease, 30% difference, so a 70% drop in hospitalizations, which is pretty remarkable. These were used fairly early, although that's an evolving story about whether or not there's benefit for this a little bit later on. Some mixed data there, but I think we'll get some more information about that soon. Right now, the EUA calls for using this in a pretty broad swath of the population. BMI of 25 plus, which already puts you at 70–80% of adults in our country. Then if you start adding in underlying conditions, you get a lot more people. So the vast majority of people who are getting COVID-19, except for those younger people I talked about who are skinny and generally healthy, wouldn't be candidates for this necessarily, but most everyone else is. And we've been giving this a lot. And EUA calls for use within 10 days of symptom onset. So here's more data. Oh, it didn't come up at the top, but this is for BAM, EDI. This is a New England Journal paper, very similar Kaplan-Meier curve. You can see the relative risks and some of the absolute effects. This comes from guideline, the IDSA and NIH guideline panels. This is the NIH. And then Sotro, similarly, if we look at this, the proportions hospitalized, proportions going to an ED, et cetera, really just no deaths in the Sotro arm, 1 in placebo. This is the kind of thing that we're talking about and why this is benefit. Severe critical, progression, 19 versus 2. So again, this is why we're making this available and why I think it's important for helping keep people out of the hospital. How do they work against the different variants? So CASI-MD has been the go-to because it does have pan-variant coverage. It's not that both of them are active against all the variants, but one of them at any one moment is. Sotro also has activity against all the variants. BAM, EDI, it's a little bit more complicated. For right now, all you have to know is it is active against Delta. And so that's why we're able to use it. If we see a shift from Delta, we're not going to be able to use this again. The other thing, and we'll talk about it in a second, is that CME can be used for post-exposure prophylaxis and can be given sub-Q for that especially. So that means somebody who's in a household who's been exposed, who also has some risks for getting severe COVID, and again, those are fairly broad, could be eligible for sub-Q or IV administration of CME. That's not the case for BAM-EDI. Supplies of CME have been okay. We're always a little worried about this. Our utilization has been tremendous. We're giving about 900 doses per week across UNC Health, and that's almost all treatment and not post-exposure prophylaxis. We have some BAM-EDI on hand, so we'll use that as we have to for treatment. As you probably have heard, the state has taken over allocation rather than us getting this directly ourselves from the source. So much like vaccinations, we now have to request an allotment and get an allotment. If we don't administer, we won't get as much. The more we use, the more we'll get in the future. I mentioned post-exposure prophylaxis, and here's the data for this. And this is really important because a lot of people know about monoclonal antibodies now for treatment, but they don't realize that it does have authorization for post-exposure prophylaxis. And this is a household study that really identified the use of this. Again, you can see a really impressive Kaplan-Meier curve. These are people who are in a household within 96 hours after a household contact have received a diagnosis of COVID-19. So we can offer this. We have this at Meadowmont. We're trying to bump this up now that we have some supply and now that the number of cases of COVID-19 have started to drop. So this is, again, really important. Inpatient, I talked about this before, what we have available. To summarize it, there's really nice recommendations from the NIH. They're thoughtful. They're evidence-based. I think they have balancing the different data that are available and reflect what we do clinically. So if anyone is really interested in this, it's basically what you're seeing here with some caveats and some nuances that we could talk about. But I do think that these guidelines, breaking it down by people's hospitalization and oxygen status is important. One thing I will mention is we're seeing a lot of people come in on steroids who don't need steroids. And I'm not showing you the data, but from a very large study in the UK, COVID-19 outpatients who get steroids, we're concerned may do poorly. In a study of hospitalized patients who did not require oxygen, steroids increased mortality. So please don't give steroids to people who are outpatient unless they have another need for them. And if they're not on oxygen, don't give steroids. When people are on oxygen, that's when we see a benefit of corticosteroids. But if someone's wheezing, they have reactive airway disease, I get it. That's okay. But in general, just to treat COVID, I would not give corticosteroids. There are resources. There's lots of resources, just a matter of trying to find them. If you're familiar with our UNC dashboard, the intranet dashboard, look for this. This is when you hit the pink COVID box. Under treatment guidelines, if you were to click on that, you will get inpatient guidelines, outpatient guidelines, and then a whole bunch of information about monoclonal antibodies and post-exposure prophylaxis and treatment, including a lot of what Dr. Weir is going to go over. So there are resources. I apologize, sometimes it's just really hard to find them. There also is a monoclonal antibody UNC page. If you Google UNC monoclonal antibodies, it's going to pop up to be the first one. There's a video. We're working on getting it all translated into Spanish. It's almost there. But this is, again, a really important resource. So I know I covered things kind of superficially, and I'm sorry about that. There's a lot of information, but I want to make sure there's time for discussion for Sam to talk a little bit more about if you're interested in ordering monoclonal antibodies, like how do you do that? What's the process? So I'm going to stop sharing my screen and turn it back over.
Thank you, Dr. Wall. Dr. Weir, would you like to share your screen?
Yes, I think I am now.
Okay, great.
So, yes, thank you, Dr. Wall. It is sobering to see how this new infection has spread so rapidly and has had such devastating effects. And I think all of us who went into healthcare wanted to make a difference. And So I want to describe for you how, in practical terms, within our EPIC system, either those of you that use EPIC day to day in your clinical work, or those who use EPIC for your patients who are in the hospital, or to monitor them, EPIC CareLink. I wanted to show you how to do this. So I'm displaying a version of EPIC that is called our proof of concept, so that there's no PHI here. This is a patient, Harry Potter, who has had is used a lot by our analysts here. And what I've done is I'm looking up this patient to do an orders encounter. So actually it looks like somebody else has already done this. But when you want to do an orders encounter, what you go down here is you go to add the order. And all you have to do is type 3 characters here, MAB. And what you'll see is the request for COVID therapeutics. And you want to, just like you do any other order, you want to accept that. And then I encourage you to go, I hope you can see the edge there, but go down here in the corner and favorite this, so that if you have to use it again, it'll be in your favorites, and it'll be easy for you to do. And so just accept that, make it part of your favorites, and then you're good to go. Now back to the order itself. So I'm going to put this in the middle of the screen. You'll see it's a future order. It goes in for today. And the first question here is, does your patient have a positive PCR or antigen test result, and the patient is aware of the result? So we've received some referrals and the patient didn't know they had a positive test. So please make sure that you discuss that with your patient before you place this order. And I'm going to go through this both ways. This same order works for either a patient who has COVID or for post-exposure prophylaxis for patients who have a close contact. So let's do it first for those who have a positive test. And then you'll see that we ask you to tell us the date of the first symptom of COVID-19. When we are scheduling these, there is a very clear advantage to doing this as quickly as possible after the onset of symptoms. So you want to document when your patient's first symptoms were. And then we have a couple of 3 very high risk areas here. So is your patient immunocompromised? Is patient's BMI greater than 35%? Or for children, you can see the cutoffs there. Now this area here, is the patient willing to drive more than 1 hour? Very important. So one of the issues that we've had is that the demand for this service is greater in the eastern part of the state and in the western part of the state. But the capacity that we've developed for monoclonal antibodies is more right in the Triangle area in Johnston County. So I would, and I've done this when I've ordered this for my own patients, I've encouraged them to be willing to drive more than 1 hour to get this treatment, because again, we want to do this as timely as possible for our patients. Let's go back up here and say it's not a patient with COVID, but a patient with a very recent exposure that we want to provide post-exposure prophylaxis. So if you say no, you'll notice the first question here changes. It's now the date of the documented first known COVID-19 exposure. And so let's say this patient was exposed yesterday. And then the same questions in terms of the high-risk areas. Let's say this patient is immunocompromised, active cancer treatment. Just a very brief thing about what we mean by immunocompromised. Patient's BMI is not greater than 35%. And again, this question about willingness to drive. This is especially important for post-exposure prophylaxis because we're not able to provide that, again, because of the demand from patients with early COVID itself. And so we really are hoping that the patients are willing to drive for at least an hour to get this treatment. Then you just accept it. As with any order, you have to diagnose, associate it with a diagnosis. In this case, it's a post-exposure prophylaxis, so we would use the exposure to COVID-19 virus, and then you just sign it the way you would any other order. A little bit about the downstream workflow, so you'll know how we're doing this. This goes to a system-wide central work queue that nursing and staff work to prioritize the patients, help them get into the most convenient, hopefully, place for them to get the monoclonal antibody, but it's also the most rapid place that they can get it. And then they get scheduled, they go in for the service. Monoclonal antibody infusions last about 90 minutes, but then they have to be observed. And so they do need to be prepared to spend upwards of 2 hours for the service. So that's the sort of nuts and bolts in the way that we've built this out in Epic. Of course, the first choice is to help as many people as possible to get vaccinated. And those conversations are important. And we all have relationships with our patients. And so we're in the best position, I think, to help patients explain their concerns, and hopefully we can help them as they voice their concerns. We can help address those and perhaps help patients make a decision to get a vaccine. I know once we now have the vaccine in most of our primary care clinics, it's been, for me, that's how I judge a good day in the clinic, is that somebody got a vaccine. That's it for what I wanted to show, and I'm going to stop sharing now, and maybe we have a little bit of time for questions, if there are any questions in the chat.
So we do have some questions in the chat. Some of these, it looks like Dr. Wall is responding, but I'll go ahead and read some of those off. Should household contacts of COVID positive patients continue wearing masks in the home if they've already been exposed? Does continued exposure and/or viral load play a role here in terms of increasing probability of infection?
Yeah, this is a good question, and I could understand the concern. It's a matter, a little bit of just chance. And so if somebody has not been infected yet, that doesn't mean that they can't be later on today or tomorrow from an infectious source. So even though people start to decrease their shedding, as I showed you with the pink dots and the green dots, they can continue to shed. So I know it's hard, especially if you're taking care of a small child. It just may not be practical. But I think where it's possible, I would mask indoors if you're taking care of a family member. And I think this applies even to like influenza. We're learning a lot about how we can decrease our risk for other viruses, other respiratory viruses besides COVID-19. And so, yeah, I would do so if it was me, if I could practically.
Okay, there's a number of questions on workflow for non-UNC physicians to refer patients for monoclonal antibodies. Dr. Weir, would you like to address that? If they're not on Epic, we do have UNC CareLink. So if you're a member of UNC CareLink, we will be generating a specific tip sheet on how to place those orders inside of CareLink. But maybe there are some providers on that aren't on CareLink as well.
If they're not on CareLink, then we do have a 1-800 number, and we can get that number to people. They can call in. The order from you is transcribed into Epic, and then it joins this same work queue where the nursing staff review the requests and help the patients get scheduled. So that's the way that works.
And can patients initiate this request, or do they have to have a physician order?
We do get patients who call, and we do go ahead and transcribe those. They're not obviously an order from a physician, and so they then have to be, they get more evaluation when the nurses call, if the patient is the one that initiates the request.
Okay. Have we looked at vaccination requirement in patients who have recovered from COVID?
It's a really good question. Yeah, I wish we had like 5 hours to talk. So this is a question that I am not sure we know completely the answer right now. There are some mixed data. One is that's compelling to me right now is that in Kentucky, and this was an MMWR that you might have seen just from about a month ago, they looked at people who were infected last year and then looked at their rosters of people who were testing positive this year, and they saw that there were some people who had gotten reinfected. And they looked at their vaccination status. And interesting, so A, reinfection happens. B, if you were vaccinated, you had a much lower risk. So the proportion of people who had gotten reinfected was much lower than what you would expect if there was no effective vaccination at all. So vaccination protected people from reinfection. So that tells me it does something beyond natural infection. Now, that's pre-Delta to sort of pre-Delta to Delta. Does getting infected with Delta now do something different in the future? Again, there's a smaller data set from one of the HMOs in Israel that suggests that maybe, remember, they're using Pfizer, which is a good vaccine, but maybe that they're seeing people with natural immunity had better antibody levels, which is not the whole kit and caboodle when we talk about immunity. But if you base it upon that correlate, it looked like antibody levels were higher in people who had natural infection. But we don't know how long that lasts. We don't know the breadth of that. And in that study, people who had natural infection and got vaccinated had the best responses of all. So I take it to mean we should probably vaccinate people who've had COVID-19. And the only reason not to is because, and I'm not trying to be offensive here. I'm not trying to be dismissive, but like we don't hand wring about, like, I know there's differences between this and tetanus and this and pneumovax and this even in Shingrix. But it's just a vaccine. Like, so if you've had COVID-19, taking a dose of vaccine, I think will give you broader immunity. And again, we'll learn more about this, but I don't think like something bad is going to happen to you. Half of humanity has had a COVID-19 shot. It's not showing. There's nothing showing up that looks like this is going to be a big problem. So, yeah, if it was me and I had COVID-19, I would do everything I can not to catch it again, and prepare myself for future variants. And I think a good vaccine on top of that would probably protect me better than people who are fully vaccinated and better than people who had only natural immunity.
Lots of questions coming in. This is going to be hard to get to all of them, but maybe just to follow up on what you're talking about. What if someone got Pfizer vaccine but what would happen if they get a Moderna vaccine as well? Are you recommending?
Probably nothing. So yeah, these vaccines are very similar. The construct's different. The construct's the same. They're not different. The dose in the Moderna is a little higher, and probably giving it 4 weeks rather than 3 weeks after the first is why Moderna is better. Mixing and matching mRNA vaccines in my book is not a big deal. The FDA and the CDC seem to be stuck on this for reasons I'm not sure about. I think a bigger question is, what about people who got J&J? Can they get an mRNA vaccine? In Europe, they have done heterologous vaccination where people who've gotten AstraZeneca, an adenovirus vaccine, have gotten an mRNA vaccine, and they see great responses. So I think we should follow the data, but I do think the data suggests that you can mix. But right now, the CDC, the party line is stay in your lane. If you've had J&J, stick with J&J, even for the boosters. But they do allow for the mRNA vaccine switching if there's a supply problem. So if clinic is out of Pfizer and you got Moderna, you can get it. But but right now the party line is to not mix. But scientifically, I don't think it matters.
Is there any utility in checking COVID antibodies post-infection or post-vaccine?
Yeah. Again, the party line is that how does it help you? What do you do? But I do think there are circumstances where it could help you, and I am certainly guilty of ordering this in patients. So I think it's really important for people sometimes who are immunocompromised, who want to know. And again, antibodies aren't everything. Cellular immunity may be really good, and we don't measure that. So I don't know that I could tell someone. But if you see no antibody levels, that's concerning to me. And if someone's on the fence about a booster, or something else. So I like to do it when it's going to change something or influence something, not just for curiosity's sake. But I do sometimes do it in those special circumstances. But just to do it, just so you know, I think that that's faulty, and I'd be really concerned. And we also don't know how to interpret the levels. So I would be concerned about using this, except when it's going to help you make a decision.
Okay. Let's see. I had a question for Dr. Weir. I'm looking for it. Let's see. How soon after placing the order should the patient expect to hear from UNC on MAB?
I looked at the work queue today, and all of the requests came in either yesterday or earlier today. So they're turning these around very quickly now. And so patients, I think it's fair to say that a patient can expect to hear within 24 to 36 hours. And it would be very helpful if they get a call from UNC that they go ahead and stop whatever they're doing and answer it, because we want to get them as quickly as possible.
And the question came in, are there FEMA infusion sites available in North Carolina as well?
There's about 6 of them. I think, I'm not sure all are at 100% ramp up, but they're in the East and the West. So we have an incredible operations team at UNC Health, and so they're very aware of these, and they do refer people to them as well. So I just don't think they have a huge capacity is the problem, but either some of our UNC centers don't have a huge capacity, so anything helps.
Okay, 2 other questions I'd like to cover. One is regarding pediatric vaccine being approved, possible timeline, and the second is they've asked about long haul patients and maybe getting like they're not showing any interest in receiving a vaccine. So maybe you could address that.
Yeah, so for pediatrics, we know that Pfizer and Moderna are getting near the end of their studies. For kind of unclear reasons, sort of clear reasons, they were asked by regulators to increase the sample size, ostensibly to look for rare events like myocarditis that slowed things down. But it looks like their top line data they've already started to get. So fingers crossed that probably within the next month or so, we'll hear about 5 to 11-year-olds. For younger than that, what I'm hearing from others, and I don't have any direct line, is it's going to take much longer, and we might see that, Q1 of next year or Q2 of next year for younger kids. But 5 to 11-year-olds, thank goodness it's not right now, though, because with doing all the booster shots, it's taking a lot of person power, along with the monoclonal antibodies and everything else we're doing, taking care of really sick people who are unvaccinated in our hospitals. So I'm kind of, I think, glad that we don't. But I want 5 to 11-year-olds to get vaccinated because they can get sick, they can transmit it to others. So I think it's important to do that. But maybe I'm hoping, fingers crossed, we'll see something October, November.
Okay. And anything on the long haul patients, their resistance to having vaccine?
Yeah, it's hard. It's hard to convince people. One of the only things that has really helped some long haul people has been vaccination. And I've seen people who've gotten vaccinated, and that was the one thing that made a difference for them. So, I would share that information with them. There's testimonials about that. But yeah, I would try to share that. There's not much else you can do for those folks. And I do think there's going to be more data about people who have natural infection, just how durable that is. And maybe in 6 months, we'll all say they don't have to be vaccinated. But right now, I think the data indicates that there's a benefit over a risk, and the risk is so low. So why not do it?
Okay, great. So I just want to let everyone know that if you are not on UNC CareLink and would like to request an account, you can go to unccarelink.org and select Request New Account. That will give you kind of a read-only entrance into the patients that you have at UNC and your ability to order monoclonal antibody for a patient. So I also want to remind everyone we are recording this session. We will email this. The link will be available, and we can email out the monoclonal antibody order tip sheets for UNC CareLink. Any other last thoughts, Dr. Wall or Dr. Weir?
No, I appreciate it. And please, I know we didn't get to all the questions, and I'm not going to know how to convince anyone's 24-year-old to get vaccinated. But if you do have questions, please email me. I'm happy to respond to emails. I'm happy to share the guidelines if you can't get at them. Again, these are UNC guidelines. They may be different from system to system, but they're pretty well thought out by our infectious disease and other colleagues. And I appreciate everything that Dr. Weir has done to really operationalize. It's become a very smooth process. So let your patients know about it, share the news, and we'll try to get even more people treated out of the hospital.
Great. Thank you both so much for your time and taking the time to put together this presentation and let everyone know the latest. So thank you all. We appreciate it.
Bye-bye.
Thank you.
How long do you wait after the infection to give the vaccine?
Is it 90 days or?
How do we get the link?